just still working on these. But hospital-acquired conditions are key in this area. So it's just like if my patient gets a deep vein thrombosis after a total knee. Now, we're not on units with total knees, but if they end up getting a PE from the deep vein thrombosis that they had because of their total knee, they're going to end up in critical care. So that'd be something that I would be checking off. Okay, this person did have a total knee 4 days ago. Now they came in with sudden onset shortness of breath, stabbing chest pain, non-radiating, and got admitted to critical care. And absolutely, some of them don't even survive it. So just keeping that in mind. Another big group that they're having high incidence of DVTs post-surgical, and they're not on this list, but it's your bariatric patients. And losing quite a few of those because of non-adequate anticoagulation post-surgical. So just keeping that in mind. Catheter-associated urinary tract infections.
Big, big, big thing.
We're not seeing a lot of central line infections because they went to all kinds of protocols to try to decrease that. Falls are another category in this. And almost every unit has a board that tells how many days it's been since the last fall. And you like to see 6,000, but most of the time it's 1 or 2. Okay? So these are pretty simple things. Again, date and check. And again, they should be covered in post-conference too. We should be hearing, anybody have any CMS events or never events that you've had happen? You see a whole bunch of them are diabetic options. People not controlled with their diabetes. Surgical patients, as Ms. Doolin will reinforce, require to be below 180 within 24 hours of the surgery. And we don't do that well at the medical center. That's not well at all. So you'll note that in a lot of patients that are still 250, 300, and we're way past that. And they're getting dinged on their, I can't remember the name, SCIP? Is that the SCIP protocols?
And then the thing is too, this was something that I think it was when Jamie was still the manager at 4D. We didn't want to wake them up. Okay. But it was not being done at night.
So again, there are national requirements on purpose because they improve patient outcomes. And again, you don't want to be a hospital in the bottom 100 in the country. You want to be in a hospital that's the top 100 in the country. That's what you want to be moving towards. Because then you're proud to work there. Because you know you're making a difference for patients' outcomes.
And these numbers are available to everyone on the internet.
Everybody in the world.
And how many people in here that was in my clinicals last year remember what the blue line on any piece of material that you use in surgery or out of surgery means? Radio tape. Radio tape. Yes, I'm so proud. So it's obtained objects within a patient as well as one of the.
You can't have those things left in there.
No, that's why you gotta count. Count.
Then I put this in here just as a resource so that you had normal lab values. Now the hospitals will have what their lab values are too, so I'm fine with that. But sometimes they don't always have it easily available to tell what the normals are, because in your concept map, you're going to need to define abnormal, and then think about why are they abnormal. It's not just a matter of, oh, this isn't normal. We're not stopping there anymore. We got to move on to think, well, let's think about why is this abnormal. That's the critical thinking component. So these are going to be just a list so you'll have them available. Because I hear everybody telling me, I don't know. Then here is for those that are at the medical center, the parking option. As far away as you can, that's where you need to park.
That's the easiest.
And they will take you out if they see you. Believe me, somebody's out there watching for redcoats. I'm serious. There are people out there, and they run right into the hospital and they phone people and say, I saw a student parking in that place. They really do. Or black coats in the case of the guys. But you'll be in trouble one way or the other. And we will hear about it, and I don't really like to hear those things.
I've forgotten to take my faculty staff off when I've worked in the ER before, and they're looking and I'm like, really, I'm in seal blue. Yeah.
There'll be nobody at faculty would ever wear that. Okay, the next one is your clinical eval. Remember, your faculty member will have this, And it does require, you don't have to make a copy of this one. This is the one that we fill out that goes into your folder. So it has the midterm and the final. You will be required on the 15th, 14th or 15th, whichever Monday or Tuesday day you are, that you will have